This video for Chapter 7 on patient assessment is going to include information about working on determining the level of responsiveness of a patient. So a couple of key terms here, just knowing the AVPU scale, understanding what level of responsiveness refers to, or we'll call it LOR. Let's go ahead and take a look. So in the overall patient assessment process, once again, we see the 5 parts of patient assessment, and we want to pay attention to that. We're going to be dealing with level of responsiveness pretty early in terms of where we are. So that primary patient assessment, looking at level of responsiveness, just comes down to, is the patient alert and able to communicate? If they can speak normally and we don't see any major bleeds, this is a good thing, because the airway, the breathing, and the circulation are intact. Just simply asking, hey, are you okay? And if they reply, I need help, you know that they have a pulse, they have an airway, because their level of responsiveness is such that they're alert and able to respond appropriately. Speaking means that the airway is patent and they're breathing. And we know something about their level of responsiveness, or the D in ABCD disability. Their level of cognition is fine. They understand you. For fully responsive patients, again, always introduce yourself. You can just simply say, hey, I'm Paul with Ski Patrol. Can I help you? And part of that then is also going to be to determine consent. Remember, for a minor patient, ask the parent or guardian who's present for permission. If an unresponsive patient is the one that you're dealing with, or the child is alone, you're fine to operate under implied consent. Now, while you're talking to them, just maintaining that calm demeanor is going to be important, but you don't want to come out and say, hey, you're going to be all right. Okay, they're injured or ill, and so we certainly don't want to set up any sort of set them up for something that, understanding that they're still in pain or some procedures might need to happen. If the patient tells you that they don't want help, that's a refusal, as long as they are able to do so and they're competent. If you're concerned that the patient has a problem, stay nearby and just make sure that they continue to be okay, because they can initially refuse but change their mind later on. A good way to introduce yourself is to get down to the patient's level on the snow, and that also gives you a chance to better assess the initial appearance, looking at things like skin color, temperature, and moisture to make sure that they're perfused. It gives you an opportunity to perhaps reach in and check that radial pulse for rate, rhythm, and quality, and see what's going on with them. Now, more particularly with the level of responsiveness, if someone is not completely responsive, we're going to assign a level of responsiveness to that. Just a quick measure of where they are in terms of their awareness of the particular environment, and it's a continuum from being fully alert and oriented to various levels of unresponsiveness. One way to do that is to just question the patient. We can ask them their name, we can ask them where they are, the approximate time of day and day of the week, and the events leading up to the situation. When we do so, we're talking about the patient being alert and oriented to person, place, time, and event. If a person responds appropriately to all of those, we can say that they are A and O times 4. Person, place, time, and event. And we always ask these in this sequence, mostly because of persistence of memory. The patient's probably known their name the longest. They've known where they are since probably they arrived at the ski hill this morning. Being able to estimate the time of day is a little bit more transient. It changes. Is it late morning? Is it lunchtime? Is it early afternoon? And then the events leading up to the situation are the most immediate thing, and probably the first thing to disappear as we question the patient. If we say, hey, who are you? And they say, I'm Bill. And we say, where are you? And they say, I'm skiing at Copper Mountain. And we say, about what time is it? And they say, oh, I just ate lunch. It's probably about 1 o'clock. And you say, what happened? And they say, I don't know. It's the last thing, the least persistent thing in their memory is the one that's disappeared. That patient's A&O times only 3. It could suggest a potential neurological problem. It's going to be considered a little bit abnormal. Now, another scale that we use is the AVPU scale, and that just stands for alert, verbal, pain, and unresponsive. We see it here in table 7.1. If a patient is alert, they're fully awake, they open their eyes, they make purposeful movement. If they don't open their eyes spontaneously but respond to a voice or a loud sound, they're verbally responsive. If they respond only to painful stimuli, that's a painful response. No response at all, they are unresponsive. Okay? First determine whether the patient is awake and alert, and then we would score them A on the AVPU scale. Again, we're looking for them to track you with their eyes and make purposeful movements. Responding verbally is that second level. If they don't respond to verbal stimuli, you can attempt to elicit a painful response by pinching the earlobe or pinching the trapezius muscle. That's that large muscle that's triangular shape between the neck and the shoulder. You can press on the base of the fingernail with a hard object, although I've never seen that done. If you do get a response, we would note them as P on the AVPU scale. No response to pain is a U for unresponsive. So in summary, we want to assess the level of responsiveness. It's going to be part of that primary assessment. Are they alert and able to communicate? How alert are they? We can use the A&O times 4, 3, 2, or 1 scale. We can use the AVPU scale. And it's also a good thing if they're alert and responding normally. Hey, we've got a clue that the airway and breathing and circulation are intact.